Hi, I'm Justin Singer. I'm a dual-trained endovascular and open cerebrovascular neurosurgeon at Spectrum Health in Grand Rapids, Michigan, and I'm here to discuss minimally invasive parafascicular surgery with you all today. Sorry I am not able to be there with you in person. I hope everyone is staying safe, and I hope you find the content of this talk educational and a great introduction to minimally invasive parafascicular surgery, which has really become a very robust part of my practice for both vascular applications, including AVM and intracerebral hemorrhage, as well as tumor. Just to give you a little bit of an overview, this is the state of Michigan, and where my arrow is presently, this is our central hub in Grand Rapids, and we have multiple referring centers that are part of our health system throughout West and North Michigan, and we serve a population of approximately 2.5 million people. We are a comprehensive stroke center, taking care of the full gamut of neurovascular pathology. We also have a neurosurgery residency program and a neurology residency program, and are the largest comprehensive stroke center in the entire state of Michigan and one of the largest in the Midwest. Those of you who may not know so much about Grand Rapids or the state of Michigan, Grand Rapids happens to be a very popular beer destination in the United States, and anyone who's ever in town and would like to come hang out with us, we'd be more than happy to host you and share a pint once travel and life gets more back to normal. So a little bit of an overview. In general, there are multiple challenges that we are all familiar with respect to subcortical surgery and surgery for lesions in this space. And there really are multiple challenges related to accessing the subcortical space related to deep and vital structures in the white matter tracts. There's also substantial issues related to retraction with brain tissue creep, which we're all familiar with around a narrow corridor, and uneven shear forces distributed around the field related to traditional malleable type retractors or other retractor systems that you might be familiar with. In addition, there are some limitations related to endoscopic visualization and sharing light down the field when you're operating in a deep subcortical area. In general, lesions in the intraventricular space and within the white matter end up being very, very challenging, and there are vital structures that you end up traversing in this, and there needs to be a solution to help access these spaces. And I think what you will see is that the minimally invasive parafascicular approach is an ideal approach for performing procedures in this area. In general, this is more of a targeted strategy or a deficit-sparing type approach, which utilizes image interpretation and trajectory planning with DTI and high-resolution MRI, intraoperative navigation for planning your trajectories and optimizing your approach to lesions in corridors which travel parallel to your white matter tracts and fiber tracts, and minimizing any traversing of these vital areas. In general, there is a growing body of evidence with more than 100 publications and 1,700 patients reported within the literature discussing the approach of biopsying, management of intracerebral hemorrhage, cavernous malformations, gliomas. The full gamut of pathology really can be addressed with this approach, and really is an important armamentarium to our neurosurgical specialties. Key concepts overall for MIP surgery are the access, which is a transfocal parafascicular approach. There is a standardized automated collection system which allows us to preserve the tissue during resection and also preserves it for pathologic interpretation and testing, and then automated removal with complete control by the surgeon with a foot pedal with the Myriad Novus. Why does it matter in terms of accessing, and why does this solution perform ideally for this? Overall, we presume that the transfocal approach, based off of the site architecture of the gyrus, ends up being the safest place with least injury to the neural structures. We, assume that all areas of the brain are vital, and therefore traversing the transcercal corridor limits our injury to the brain. It really ends up being an avascular plane to access with MIPS during cannulation, and leaves the layers undisrupted as you're traversing through the sulcus overall. In addition, parafascicular approaches are important in general because we travel parallel to the white matter tracts in order to minimize the shear forces along them. We choose trajectories, and there are typically common corridors, whether the most common of which is usually an anterior approach, posterior approach, occasionally a lateral approach, and these all travel parallel to our common fiber tracks and minimize our shear forces. We never want to be traversing these in a perpendicular plane. The even distribution of force around the entirety of the field is also important. And it reduces the amount of brain that we traverse in general because we're traversing deeper within the sulcus where we enter and not from the cortex where we just have a general greater length to potentially injure fibers as we're traveling down. And then we have this nice distribution and even displacement of neural tissue around the tube circumferentially. Overall, this has evolved over time and ends up being a patented vent design, which helps to equalize the pressure as you're engaging. There is an 11 millimeter and a 13.5 millimeter tube, with lengths of 50 millimeters to 95 millimeters. 50 millimeters ends up being fairly commonly used for certain tumor pathologies. 95 is actually reasonably easy to work through and is most commonly used for long trajectories for deep subcortical intracerebral hemorrhage. In general, this is intended to develop a gentle and sequential dilation as you're going through the sulcus with even distribution of force with a very small edge. The tip here of the obturator ends up being approximately 15 millimeters with a little bit of a bevel to the edge. And we have different cannulas and different obturators for insertion for the variety of different sources. This allows for a very nice bimanual technique to work down the tube, particularly with good visualization and a good light source, of which the Myriad Novus ends up being a really important element to that. So this is not just another tube to help you access the space. It really is from the tip to the stem, a very vital element that helps you access deeply and maintain safety during the course of these procedures. The Myriad Novus is an automated, multifunctional, non-heat generating surgical tool. It is essentially an aspirator, which helps us resect tissue throughout the procedure. It has a side-mounted aperture, which allows you to ingest, and the aperture can be changed to have a biting mechanism, which can be turned off and on and provide only suction or aspiration with this side mouth biting mechanism. It is non-heat generating, and you can vary the aspiration with the foot pedal. The side aperture ends up being in around this area, and you can manipulate this around the field and actually adjust it with a toggle so it can point in different directions. The Myriad Novus edition has provided an additional light source deep within the space, which allows you to add additional light, which is a casual limitation. One of the benefits of the Novus is that it's not just usable down the tube, it can also be used down an endoscope intraventricularly, also particularly useful during endoscopic procedures and other tumor resections as well. Complete control and variable aspiration, mostly with the foot pedal, and a dial on the switch over here, which you're able to control as well. Here's an example just to highlight the Myriad Novus light source. This is a picture from intraoperative with the light source on with really bright illumination and the Novus without. It actually is a very strong light source, and have used personally in instances where you could have minimal light from your microscope and really illuminate the field quite well. And of course, as 5-ALA is an important element to surgery, as well as other elements of fluorescence. This is an exciting area for the future for us to continue to investigate additional applications. And here we're just showing some functions of the Myriad, where there is a foot pedal where you are able to turn the cutting on and off. You're able to kind of do the shaving motion and manipulate. In addition, it is non-heat generating, and it is atraumatic and only really bites within the aperture. Again, this can be used in a variety of different settings through the Brainpath port. In addition, it can also be used through an endoscope for intraventricular or other endoscopic procedures, as well as endonasally or in other tumor fields. In addition, we have the ability to preserve pathology in a specimen container. Given the non-ablative technology for the aspiration, this provides a good source for storage of pathology without any degradation of the tissue for appropriate testing, and really meets your oncologic needs for pathology and diagnosis. So MIPS ends up being a full surgical solution that really utilizes a system-based approach for accessing the translocal space using pre-planned corridors with intraoperative navigation. We use the appropriate access with the obturator and the appropriately length sheet. Visualization deep in the field is also essential. We have the ability to resect, and then, of course, we want to be able to, in the future, deliver therapeutics on a patient-specific basis. And this is just an index case to highlight the usage here. This is a intracerebral hemorrhage within the basal ganglia, indicating here that we did target a posterior approach. This arrow is highlighting the internal capsule, which is displaced medially, and you can highlight in this area over here, and here is the hemorrhage. What we're able to see here is following the resection, we have restoration of the posterior limb of the internal capsule and decompression. And frequently in this instance, particularly with laterally based intracerebral hemorrhage, these patients actually end up doing quite well. About a week ago, I performed a 17 cc subcortical lateral basal ganglia evacuation with a MIPS posterior approach, very similar to this one, where the patient almost immediately postoperatively had significant improvement in his strength and presently doing well at his rehabilitation facility. And this is just to highlight overall approach and access during the procedure. Typically, we do about a 3 centimeter craniotomy, a small dural opening. The dural openings we tend to want to be small because we don't want to lose a lot of pressure transduction down the tube. In addition to this, we tend to try and limit use of steroids and hyperosmolar agents because we want to maintain intracerebral pressure during the cannulation period, and this helps to evacuate the pathology up the tube kind of spontaneously, particularly for hemorrhages or even certain tumor pathologies which appear to be soft. This is a peer-reviewed meta-analysis that was published in 2020 by Mansour et al. There were 29 studies that were part of this meta-analysis. Overall, surgical morbidity was 8.3% versus traditional retraction, which was approximately 29%. Really, the Brainpath is designed to reduce parenchymal injury compared to traditional retraction and other elements for accessing in the subcortical space. Gross total resection can be achieved in approximately 80.6% of tumor cases. Of note, this is really great technology utilized for colloid cyst procedures, and in literature reported 100% success in resection of colloid cysts. There's a 90% evacuation rate in more than 65% of intracerebral hemorrhage cases, and 100% diagnostic yield in published biopsy studies. And here is just a few examples of cases which I have performed using the minimally invasive parafascicular approach. The video here, which I will show in a second, is not in this first case, but this was actually my first procedure performed with this approach. And you might wonder why I would choose this one. I think case selection early on is very important. And while this does come to the cortical surface, I thought this would be an ideal case because we've all been in these procedures where you perform your corticotomy, evacuate the superficial blood products, and then the capsule collapses around you. My approach for this procedure was actually a eyebrow incision, and using a Brainpath was able to cannulate deep within the hemorrhage. The majority of the hematoma products actually vented themselves out the tube spontaneously, and then was able to work from a distal to proximal fashion without losing pressure within the cavity, and was able to continue to evacuate the procedure and maintain retraction along the edge, and then not having to fight and struggle as the cavity collapsed around me. It ended up being a very good procedure for initial experience, and have subsequently grown substantially since that time with additional cases. But I think case selection early on in your experience is very important to optimize your comfort level and safety during this procedure. And here's another example of intracerebral hemorrhage demonstrating the elements of the approach. And I think what's notable here is after cannulation, you see the hematoma products are actually venting themselves out the tube spontaneously. I'm not doing anything here. And this is a reflection really of the pressure that these hematoma products are under. Once we're able to vent and remove some of the initial superficial products, we'll then introduce the aspirator, the myriad. And see, most of these blood products are actually, with manipulation of the tube, are venting themselves into the field. And typically using the aspirator with a bimanual technique. Sometimes even with a bipolar cautery in conjunction, and typically carefully working your way around the tube until you have the tube completely removed. And then decannulation. Decannulation always ends up being quite gratifying because rarely the walls are injured and the cavity slowly collapses back together, and you can inspect for hemostasis. A nice, more relaxed pulsatile brain following the intervention. And here's a little bit of a different case in a 12-year-old boy who had an intracerebral hemorrhage associated with a small arteriovenous malformation. This case was undertaken where I had a little bit more experience and grown comfort level. This is a very small arteriovenous malformation, approximately 1 centimeter. No residual AVM postoperatively and a good evacuation. I typically will make approximately a 3 centimeter craniotomy, linear opening in the dura. I'll tack back the dural edge, small opening along the sulcus. Cannulation along sulcal vessels is very safe and atraumatic to vessels given the design of the sheath and the gentle edge. When I'm targeting a spot sign on intracerebral hemorrhage or an AVM, I typically will land just adjacent to the pathology and evacuate the hematoma and slowly find my way towards the vascular lesion so I don't injure it additionally with the obturator. You have good bimanual dexterity for hemostasis. Continue to work around the field. You can get your bipolars and your micro instruments down there. Being familiar with what instruments you're able to use down this tube, typically bayoneted longer instruments are best, and what kind of bipolars you use are also important. So taking stock of these things and getting assistance from your support for these procedures and being aware what will work best on your tube will be very important for your success early on in your experience. We continue working ourselves around the tube, and just in the interest of time, I can try and move this along a little bit. Good bipolar cautery. Be able to place patties down there as well and manipulate them around the field to control and protect tissue. This is a quite small AVM, most of which ended up down in my suction following resection. Place some Surgicel in the cavity and then decannulate. And just a few additional examples of use of the MIPS approach with Brainpath. On the left of your screen here, this is a patient who had a glioblastoma in the periventricular area, initially presented with intracerebral hemorrhage. We had a left posterior approach to this area with a great resection of this lesion. I think these lesions are very accessible with this approach and ideally are performed with good DTI planning and good experience down the tube, occasionally with some additional early experience cases so we feel comfortable. And on this side, we have a pediatric patient who has this large enhancing intraventricular lesion associated with the choroid. This ended up being an approximately 6 centimeter meningioma. It was substantially calcified and hard, and was a little bit challenging to work with down the tube. But using this subcortical approach, we were able to access the space and resect this tumor with a gross total resection and no neurologic deficits post-procedurally. At this point, I want to say thank you. Appreciate your time and your attention. Anyone who has additional interest or would like to contact me for further examples, my contact information is here. I hope everyone stays healthy and stays safe and has a safe holiday season.